Assalamu alaikum. Dr. Altaf, should we start?
Yes, please. I think it is 10 o'clock, so we should stick to time and let's start. Thank you.
Sure. Thank you. Assalamu alaikum. My name is Kiran Amir and I'm the Director Operations at PARSA ECHO Pakistan Super Hub. I would like to welcome you all to our fourth session in ECHO series on inflammatory bowel disease. It's in collaboration with South Asian IBD Alliance, SAIA, a charitable organization in United States with a global presence in South Asia, India, Pakistan, and others. A special thanks to Genex Pharma for the unrestricted educational grant. Today's session is titled Mimics Differential Diagnosis. And our expert for tonight's session is Dr. Junaid Mushtaq Chema, consultant gastroenterologist and hepatologist, Lahore General Hospital. Before we move forward, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation, so you can unmute yourself for question or use the raised hand option or chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel. Link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number and email is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of spokes, the session is bilingual, but please speak in Urdu or English, whatever language you are comfortable in. If you're interested in PARSA ECHO Pakistan's publication, please fill the form shared in the chat box. I will now hand over to Dr. Jalpa, our co-moderator for tonight's session, for introducing Saya and Dr. Junaid. Handing over to you, Dr. Jalpa.
Thank you so much, Kiran, and let me share my screen first. So my name is Nilpa Devi. I'm PGY6 from Slums Hospital, Hyderabad. Today I'm going to introduce, first of all, South Asian IBD Alliance. And it's the first patient clinician-based non-profit organization in the IBD space with the dramatically increasing numbers of IBD in South Asia. SAIA has formed to create resources, research, and education for IBD patients and healthcare providers of South Asian origin to minimize disparities, dispel stigma, promote early diagnosis, and improve access to treatment. And it has three structures that is patient outreach and advocacy, professional development, and research. And SAIA's Professional Development Committee has partnered with PARSA Trust Project ECHO to educate general practitioners and gastroenterologists thoroughly about IBD, pathogenesis, epidemiology, and how to provide the best care and treatment options to patients in resource-limited settings in South Asia. And there are resources that you can go on the social media, as well as there's a website and Facebook. And I would like to share some recent updates that they have achieved, and that is that Tina Osami, and that SAIA is honored to participate in a light bulb. It's a new innovative challenge led by the patients, and she's going to present about the unmet needs of South Asian IBD community this upcoming Wednesday. And there are other recent updates that they have Crohn's and Colitis Congress, in which they have presented various papers, as well as pizza IBD care and moderated IBD reach, and speaking on culture and diet, and also diversity in IBD care. So they all are five belong to the SAIA committee, and they have their part in the Crohn's and Colitis Congress. And I would like to add some more thing, that is IBD club that you can participate, and we have recently 4 monthly. Each month we present the IBD club, and that is on the recent article that is clinically and related to the patients, that is that helps the fellows as well as patients learning. As so anyone can join, and there is a YouTube link given. Okay, let's move on to today's topic, that is talked by the Dr. Mushtaq Chema. He's going to present about the IBD mimics and differential diagnosis, and he's has done his MRCP and FCP gastroenterology, as well as passed the European Specialty Certified Gastroenterology. And he's a member of PSS as well as ACG and UEG, and he's currently working as a consistent gastroenterologist at Lahore General Hospital since last 3 years. He's active involved in health department as a spokesperson and active member of Hepatitis Control Program Punjab. And is a key person for development of software for hepatitis, gastroenterology, OPD, and indoor with PKLI, Health Secretariat, and Primary Secondary. And he's a coordinator and spokesperson for the Advanced FCPS Fellowship Training Program in Gastroenterology and Hepatology Development, CPSC. And he's currently working on some research projects, that is single central experience of subcutaneous infliximab in patients with IBD, and world of necrosis, role of necrostomy with saline flushing snare after hot exhaust attempt. So, would like to hand over to Dr. Junaid Mushtaq Chema for.
Thank you very much for the kind introduction and for the invite as well. Okay. I'm Dr. Junaid, and I'm currently working in Lahore General Hospital. So the topic for discussion for today is IBD mimics and most common misdiagnosis as IBD. Let's just begin. What's IBD for the diagnosis is a typical symptoms of diarrhea, rectal bleeding, and abdominal pain. In fact, enterocolitis is an important differential diagnosis for the patients presenting with these symptoms, and endoscopy is an invaluable tool for the diagnosis of IBD. Many patients can produce an endoscopic picture similar to that of IBD. Pathologists really rely on the constellation of the histological features in IBD, which includes basal plasma cytosis, architectural changes, and granuloma formations. Additional investigations like stool testings, imaging, and serological testing helps we have already discussed these things. I'll quickly go through the findings we usually see in the patients with ulcerative colitis. They range from mild mucosal erythema, fine granularity, and decreased vascular marking, to moderate erythema, loss of vascular erosions, and swere ulcers that's seen in the picture C, swere spontaneous bleeding, and polyps formation. The other entity that is Crohn's disease, that is characterized by rectal sparing, skip lesions, and deep ulcerations, and the terminal ileal involvement. 10 to 15% of the patients, they have atypical features, and they cannot be characterized either in the Crohn's disease or ulcerative colitis, and they are characterized as IBD unclassified. These are the pictures we usually see while doing a colonoscopy of a patient with a Crohn's disease. They can have longitudinal ulcers, cobblestone formation, and aphthous ulcerations in a longitudinal. When we see a patient with symptoms of abdominal pain, fear, bleed, diarrhea, we need to rule out certain infections that considered to be tuberculosis, Yersinia, HSV, cytomegalovirus, histoplasmosis. These GI tract infections, you need to run the PCR panel for these bugs. Infections, they may mimic IBD as well. Never miss a colon cancer with a high CRP calprotectin level. Be aware of the refractory strictures, refractory perianal fistulas, and less commonly you can see lymphomas, melanomas, and Kaposi sarcoma as well. This is a slide that gives you a very good idea of things you need to consider as a differential diagnosis. So these needs to be divided into the infectious and the non-infectious etiologies. So keeping the infections commonly from small intestine, terminal ileal bugs to the colon, like C. difficile, CMV, Salmonella, Shigella, E. coli, Campylobacter, and amoebiasis as well. Non-infectious, you can divide them into the granulomatous diseases like sarcoidosis, common variable immunodeficiencies, vasculitis like Behçet's, chronic inflammations like diverticulitis, CAD, drug-induced colitis, ischemic colitis, SRUS, and non-specific mucosal changes without any chronic inflammation like IBS, and cancers like adenocarcinomas and always rule out infections, and important is the history of exposure and the travel history. Keeping the infections, like several infections like viral, bacterial, fungal, and protozoan helminth infections, they consider to be a common differential diagnosis in the patients with IBD. For this, you need to take a clinical history addressing the intestinal many infections like intestinal tuberculosis, they can present with the symptoms like diarrhea, weight loss, abdominal pain. They can mimic as Crohn's disease. Bugs like Salmonella, Shigella, Campylobacter, and various viruses, they have an acute limiting illnesses that may also present with IBD like ulcerative colitis, and some agents like cytomegalovirus, C. difficile may complicate the pre-existing IBD. These are the certain colonoscopic pictures, and it's very hard to differentiate these just on the colonoscopic findings, keeping all your differentials in the mind. So keeping the infections, we commonly see Yersinia that involves the terminal ileum. It presents with terminal ileitis, enteritis, and mesenteric lymphadenopathy. So they usually present in those who are exposed to the mainly uncooked pork or contaminated water, and they have an endoscopic findings of colonic cecal ulcers or terminal ileal aphthous or rounded elevations of the mucosa. And the pathological clue is the aphtaloid granulomas that can be detected on the stool examination. Amoebiasis, that is another important differential diagnosis, that Entamoeba histolytica, it has a fecal-oral contamination of the ingestion by the contaminated water or the food, and it usually presents with amoebic colitis involving the right side of the colons, but it can affect the entire of the colon. This is very predominant in the in those people who have a history of travel or in the immigrants from the endemic areas like Central South America, Africa, or Middle East. They can be present in the immunocompromised, in the pregnant women, and those with high risk of invasive diseases. They have a pathological features of amoebic trophozoites and phagocytes and erythrocytosis. Have an overlapping feature with IBD. They can have a penetrating disease called enterocutaneous, rectovaginal, and enterovesical fistulas as well. Stool examination and even the colonic biopsy for PCR and histopathology can give you a very good diagnostic clue. These are the certain images that shows right side of the colon, and you can appreciate deep, discrete serpiginous ulcers in the ascending colon and the cecum. These are some images that were taken that shows, and the first picture that shows severe proctocolitis in the patients with amoebiasis. In the second one, the CT that shows multiple hypodense lesions in the liver, representing the photovenous phase. It is the amoebic abscesses. The third one that shows deep ulcerations in the right side of the colon, and the histopathological of the sigmoid colon demonstrating the Entamoeba histolytica organism that is indicated with the red cells. ACG in 2022 that proposed the patients with seemingly refractory disease and they have discrete ulcers on colonoscopy, those who have a recent travel history, they should be evaluated for amoebiasis. This is a colonoscopic picture of terminal ileum that shows multiple aphthoid ulcers involving the terminal ileum. It says a Campylobacter, that is a gram-negative bacterium that is transmitted by the contamination of the food. This is the infection that involves the left side colitis, likely representing the ulcerative colitis that can be easily ruled out in the stool examination. C. difficile, that is gram-positive bacillus, that is commonly seen in the nosocomial exposure and recent use of antibiotics, but it has been increasingly seen in the community and can coexist with IBD in the absence of any clear risk factors. They usually present with diarrhea, abdominal pain, and swear cases can lead to the toxic megacolon. And PCR testing is used to detect this organism. These are the various organisms that needs to be considered in those who are at high risk population, like those who are either HIV or those who are immunocompromised. They usually present with prolonged diarrhea and they need to be tested for these organisms. Those who have a history of a sexual contact with the male to male, they need to present with PR bleed, they have proctitis, tenesmus, and they commonly present with these organisms. They do have some overlapping features that can mimic the ulcerative colitis or the Crohn's disease, like articular manifestations may be present and upper GI tract may be affected and the granulomas may be seen on the biopsy reports. They may have like enterocutaneous and colovesical fistula formation as well. Architecture is always favor IBD over the infections. Granuloma alone cannot make a distinction between the Crohn's disease and some type of infections. They should be assessed together with the histological features and with the clinical information that is available. Diseases that can commonly present, show the granulomas on the histology are inflammatory conditions like sarcoidosis, Crohn's, ulcerative colitis, diverticular colitis, divergent proctocolitis, immune-related disorders like chronic granulomatous diseases, cord colitis syndrome, vascular diseases like Behçet's, and inherited disorders in certain drugs like immune checkpoint inhibitors, diclofenac sodium, and rarely NSAIDs as well. Reaction or to the neoplasia as well. We commonly encounter in the Southeast Asia with the diseases like tuberculosis. It's a combination of the clinical history, endoscopic findings, biopsy, culture report, and the images that are available that help you differentiate between the Crohn's disease from intestinal tuberculosis. But that may not always be sufficient. Microbial staining, like staining, culture, are widely used, and they help you differentiate the tuberculosis from the Crohn's disease, but they lack sensitivity and have a very low diagnostic yield. A negative gamma interferon assay cannot rule out tuberculosis. In the light of your history and the diagnosis, long-term course of the anti-tuberculous therapy and long-term follow-up may be necessary in certain cases. Common presentations with in terms of iliotuberculosis and comparing with the Crohn's disease, those who have like a favorable history towards the tuberculosis, they have a shorter duration, they will have fever, night sweats, lung involvement, and ascites. In contrast, those who are favoring towards the Crohn's disease, they have a longer duration. They have diarrhea, hematochezia, and perianal disease as well. Endoscopic features of like transverse ulcers and postulus ileocecal valve. Pathologically, they have confluent granulomas, larger granulomas, and multiple granulomas formations per section, and they have serosal involvement only. The radiologically involved as compared to the Crohn's, where they have a wall stratification, cone sign, and fatty proliferation. And serologically, there will be a positive gamma interferon assay as well. These are the certain images that you commonly encounter at the right side of the colon, and the transverse ulcers seen in the right side of the colon, patulous opening of the ileocecal valve, and there are pseudopolyp formation. Very commonly, this is a very important difference. Patients in the differential diagnosis of IBD, that patients are important for the differentiating between the GI tracts and involvement by the vasculitis and IBD. These symptoms, they have very non-specific symptoms depending upon the area that of the colon that is involved, and the partly because of the size of the vessels that is involved. Usually younger age of onset, multisystemic involvement, mucosal ulcerations, and extradistant involvement. GI symptoms resemble those of IBD. They have abdominal pains, diarrhea, and very rarely they can present with bleeding as well. Endoscopy is very non-specific. They can range from simple erosions, deep ulcerations, nodularity, petechiae, edematous mucosa, and vents where features is suggestive of the ischemia. However, the biopsy is non-diagnostic in the settings of vasculitis. We rarely see these vasculitis. The vasculitis of interest is of Behçet's, that is a variable vasculitis that usually presents in the age group of 20 to 40. That can involve both the sexes, depending upon the series, and it ranges from symptoms from abdominal pain, nausea, vomiting, and gastrointestinal bleeding as well. Most commonly affected use and partial tract as well. This is the clinoscopic picture that shows terminal ileum, a large, rounded, deep ulcer, and it is discretely involving the terminal ileum. So this comes in the differential diagnosis with the Crohn's disease, where the features needs to be differentiated between the radiological findings. In the Crohn's, there will be stenosis, luminal stenosis, there will be fistula formation, and the abscesses frequently, which are rarely seen in the patients with the Behçet's disease. So for the diagnosis of the vascular disorders, imaging, particularly the abdominal, CT scans, and angiography is helpful. And for the diagnosis, serological tests are also useful, although not specific. CT will show the diffuse bowel wall enhancement, dilatation, ascites, and bowel perforation in the severe cases. Angiography may show signs of vascular involvement with microaneurysm formation, stenosis, or both. Capsule endoscopy, rarely used, will help in the diagnosis of vasculitis. Certain vascular disorders like ischemia, they will have like hemosiderin accumulation, hyalinization of the lamina propria, mild to moderate inflammation, and microthrombi may be useful in the differential diagnosis of ischemia from IBD. Long-standing cases of ischemic insult, they will result in the stricture formation, scarring, and fibrosis, often differential diagnosis with the Crohn's disease. Endoscopic findings are patchy hemorrhages, edema, fragile mucosa, and segmental erythema. longitudinal ulcerations, and sharply defined segments of the involved area, mostly involving the left side of the colon. If right side of the colon is involved, it happens very rarely and has a very poor prognosis. Biopsy, there will be like edema with a vascular congestion or hemorrhage to coagulative necrosis and loss of crypts. Micro and atrophic crypts lined by the smaller irregular cells of the eosinophilic cytoplasm. Hemosiderin accumulation in the lamina propria, sometimes accompanied by mild to moderate inflammation. Together with the CT and CT angiography can be helpful for detecting the risk factors and for monitoring the ischemic enterocolitis. Serum markers like ABGs and lactate levels, among with the others, will help you assess the diagnosis and have some clinical utility as well. Drugs are very important differential diagnosis. However, awareness with the main patterns should help the pathologist to make the correct diagnosis, or at least to suggest the possibility of drug-induced colitis or enteritis. Diaphragm disease strongly suggests the NSAID injury, and there is no micro or macroscopic features that are reliably favors the NSAID-related enterocolitis. We commonly see these patients with radiation exposure, and they have a similar presentation of abdominal pain or the PR bleeding. Histological features are very helpful in differentiating the chronic radiation colitis, such as the stromal or the vascular changes, but they are less apparent on the colonoscopic biopsy as compared to the resection specimen. Basal plasma cytosis, a histological feature of IBD, is usually not present in the radiation colitis or diversion colitis. In the radiation colitis, it apparently clinical settings, CT or MR enterography will support the diagnosis of radiation colitis and its potential complications. Divergent proctocolitis, usually after the first year of the surgery, in the defunctioned segment of the large bowel, it will exclude from the fecal stream, like for example, after an ileostomy or a colostomy. Divergent proctocolitis can occur in any disease settings. Endoscopic and histological features occurs in up to 55 to 72% of the diverted segment, respectively, and the disease is often subclinical. Endoscopy in the divergent proctocolitis show non-specific changes, mucosal nodality, and aphthal ulcers. Regardless of the underlying reason of the diversion, the appearance mimic the new IBD. Diagnosis of IBD in the diverted colon in the patients without any previous history of IBD diagnosis is not advisable. Diverticular colitis or segment colitis with diverticulosis. Diverticular colitis is difficult to distinguish from IBD on the basis of histology. They usually present with similar features like abdominal pain, localized to the left lower quadrant, and may be complicated by fistula, abscess, and strictures. And in these settings, CT scan is very helpful in differentiating the diagnosis. Segmental colitis, they usually present with abdominal pain and diarrhea, and endoscopically, they will be only limited to the area of the diverticulum. Histological evaluation, there will be no evidence of any chronicity. These are some images that shows the segmental involvement in the area of the diverticular disease. Another common differential diagnosis that is very commonly encountered in the GI clinics, they have like solitary rectal ulcer syndrome. They have like pelvic floor dysfunction. They usually present with the rectal bleeding and incomplete evacuation. Endoscopically, they range from simple non-specific erythema. They might have single or multiple ulcers, polyp formation, or mass-like lesions. Diagnostically, rectal manometry or MR help you diagnosing the solitary rectal ulcer syndrome. Biopsy is pathognomic, and the findings of collagen infiltration of the lamina propria will come up on the histopathological examination. This is an image that shows an ulceration involving the first fold of the rectum, that the biopsy favors the solitary rectal ulcer syndrome. Rule out cancer, CRC, colon cancer have similar symptoms, but the colonoscope assists in separating these diagnoses. Primary GI lymphomas like diffuse large B-cell lymphomas can be mistaken for IBD on colonoscopy, and these cancers are very rare and usually presents in older patients who are usually immunocompromised, while they can present as a mass as well. These are the images that shows deep ulcers that turned out to be the large B-cell lymphoma. Diarrhea predominant irritable bowel syndrome. Lastly, the diarrhea predominant IBS can have the clinical features in common with the IBD. Patients may report of abdominal pain and diarrhea, and lab testing assessing for the etiology of diarrhea, C-reactive protein levels, fecal calprotectin levels, both of which will be in the normal range in the patients with IBS, unlike IBD. So the serological markers like and the fecal biomarkers are useful for determining the disease activity and predicting the risk of the relapse and potentially predicting the therapy response in IBD, but they are not useful for the differential diagnosis. So diagnostic utility of omistic and the applicability of these technologies in the practice is certainly uncertain. Reliable distinction between IBD and mimic requires the constant awareness of the clinician and pathologist, the wide range of differential diagnosis, and close communication between the clinicians and the pathologist is very essential. Mimics includes infections, diverticular colitis, diversion colitis, vascular disorders, drug-induced injuries, and immune disorders. Distinction between the IBD and its mimics requires comprehensive clinical assessment, including full history with the duration of the symptoms, investigations, including the routine blood tests, endoscopic examination, histopathology, microbiological testing, serological testing, imaging, fecal markers, and serum biomarkers. Thank you.
जी, if you have any questions, आप अपना raise hand कर सकते हैं. इसके अलावा we have the chat box as well. डॉक्टर जुनैद, आपसे रिक्वेस्ट है कि आप अगर स्टॉप शेयर कर दें.
जी जी. Dr. Altaf, would you like to make any comment, like how commonly do you see any of these differentials in your clinical practice? Like,
thank you, Junaid. Indeed, a very good presentation. But don't get upset that the diagnosis is so difficult and the differential diagnosis is so wide. Actually, here comes the art of medicine, where you have to really dig out a good history. And if you are able to dig out a good history, you get a very good idea on various aspects of the differential diagnosis. Chronicity, bleeding, yes or no, travel history, exposure to pathogens in particular setting, immune deficiency status. If you keep all these in mind and gather it from the history, then, it does not really become very, very difficult. Remember, I see patients with diarrhea for years, and they haven't had a stool test so far when they come to see me. And many of us will agree with that stool test is the basic test which should tell you the characteristics of diarrhea. You should have look at the white cells, red cells, or the pus cells, as you call them, the white cells, and also the presence of blood in the stools, fat with the absence of white cells and red cells indicates small bowel origin. So again, you have to take a good history, do simple screening tests, including CBC, ESR, CRP, as mentioned, stool complete, occult blood and fat, and fecal cal protected. And the differential diagnosis becomes narrowed in many situations. Sometimes the diagnosis is difficult and you cannot categorize them. I totally agree, 5%, maybe 10%. And then you have to use your clinical acumen and all the collected data to label the patient as such and treat accordingly. So a very good presentation, a very good participation as well. So we have a lot of people attending, all levels of people. So let's have some questions and comments if there are any. If there is any comment or question, just raise your hand, unmute yourself, and please come up with your comment or your question, please. Thank you. Afan, do you have anything to say on this? Thank you for being present.
Thank you, sir. It was indeed a very good presentation. Always the way you have summarized, I think it's everything is conclusive. And always chronic diarrhea, when patient comes with chronic diarrhea, there are lots of differentials. I have seen prescriptions, people have written IBD versus IBS and IBS-D. They usually do not differentiate, especially if we come to the GP level and all that. When patient is mistreated repeatedly on IBS-D, and patient when arrives to us or a gastroenterologist, we work up, then it come out, especially the main differential we encounter in our practices is Crohn's versus TB, so intestinal TB. So evaluating and differentiating these two counts a lot, and then performing colonoscopy, then reaching to ileum, then terminal ileum intubation and identifying and biopsy, then there are certain challenges. And I always advise my colleagues who are watching me that whenever they see such a differential, always do colonoscopy themselves. A qualified gastroenterologist must go to terminal ileum and rule out themselves, and never go on findings of any colonoscopy performed in periphery. So this is the thing. And सर आपके होते हुए तो फिर बोलना मतलब सूरज को चिराग दिखाने वाली बात होती है. So thank you very much.
Thank you, Afan. My message is very loud and clear. Do not make a diagnosis of intestinal or any tuberculosis without a microbial or a histological evidence. There is very, very rare situation, less than 1 to 2%, where you sometimes use a therapeutic trial, but it could be, double-edged sword. So always try and make a microbial or histological diagnosis of tuberculosis, which is not made in many, many cases. So please always strive to do that. Any question or comment? Jalpa, do you have any comment to make or any question you want to ask?
No, sir, it's already summarized by you, especially, and then Dr. Afan sir, and Dr. Junaid has given so much knowledge about all these things. So I think from participants as well, we didn't get any comments right now. So if you, yeah.
Assalamu alaikum.
Sir.
Dr. Asad Chaudhary, I'm here. Junaid, I just joined halfway. Thank you very much. It's been very enlightening and excellent talk. I'm really sorry because of some commitment I couldn't join right from the beginning. But I think whatever I've heard from you and Dr. Altaf, and the comments by Afan, everything, I think it's been covered adequately. और हमें बहुत जरूरत है पाकिस्तान में चीज को करने की, ये जो चीजें जिसकी हम बात कर रहे हैं, जो मिमिक करती हैं, उनको करते हैं. Thank you very much. Thank you.
I will also request all the participants to avail the opportunity of facilitation from SAIA. They have all the components that you need for patient care, support, advocacy, and research. So, all the components that are essential ingredients of medical practice. So, SAIA can provide you a good umbrella to support your patients and physicians, both in terms of patient support and also support to the practitioners. So Dr. Jalpa has already shown all the social media and the links that you can get in touch with. The patients can do that, the physicians can do that. So this is in collaboration with SAIA, which is very good that we are using that platform to facilitate our physicians and patients alike. Thank you.
There's a question in the chat box by Dr. Junaid Mushtaq, and if you have time, you can take it. And attendee is asking that if there is a severe colitis suggested for IBD, should we proceed for full ileal colonoscopy to confirm IBD or abandon the procedure due to risk of perforation? And the next question, that should treatment be started if there is clinically suspected IBD without biopsy?
Okay. The first one is like in the settings of severe colitis, I would like to restrict myself to rely more on the knowledge, the information I have, like the blood tests and the stool examination. And I would like to make a quick review of the sigmoid colon, and I would like to take the biopsies from either rectum or the distal part of the colon. I would not like to cross the sigmoid colon. Yes, it raises the chances of perforation, and you will not do any benefit to the patient by doing a full colonoscopy in the settings of if you are expecting a severe colitis. The second question was what is important? I would like to ask which of the infection in the mimics of IBD is most common. It's very difficult to answer like which infections are more common. It's more the history of the patients and the symptoms he's presenting, and if more idea of the common infections that usually present in the in the patients presenting with the abdominal symptoms.
Another part of that question was that should you start treatment for IBD without taking a biopsy? Well, as Junaid has already highlighted, a limited endoscopic examination and biopsy, and I will repeat, and biopsy should always be taken. As you know from his talk, it's not an easy diagnosis. So gather as much information as you can. Blood test, serological tests, stool tests, bacterial, parasitic, all these data along with biopsy, because without biopsy, it's not very easy to make a diagnosis and to treat. So I would condemn this practice of starting treatment without a biopsy. So you should, when you are there in the rectum or rectal biopsy is very safe. Distal rectum, you can always take a biopsy even in severely inflamed rectum. Thank you.
Dr. Altaf, if we don't have any more questions, I would like to take the liberty to make a quick comment. Like I'm doing a trial with Professor Gyas on subcutaneous infliximab. We started this trial like almost 1.5 years back, and we have accomplished a data of like more than 90 patients. And I've not formally concluding the results, but the limited data of like 8 to 9 months of different patients at different stages. I would like to like, if you have any of the patients of Crohn's or ulcerative colitis, you can refer them to LGH. And we have a huge donation from one of the companies of subcutaneous infliximab, and I would like to like put the patients on the continuous follow-up, and we are following a protocol, and they'll be regularly followed, and I'll ask them to send directly to the OPD of Lahore General Hospital.
Thank you, Junaid. I have come across some of these patients, and a very good service, free of charge biologicals, initially intravenous 2 or 3 doses, and then followed by subcutaneous. So, you know, this is a great service to the patients as well. And I've seen the responses. They are very good. So when you finally, it would be very interesting to see your results when you finally formulate and complete your data set. So a great service. Please keep it up. Thank you.
So I think we're done with the questions, and now I'm going to hand over to the Kiran for concluding remarks, and I can finish it.
Thank you very much. Thank you very much, everyone. This series is designed to have session once a month. We took 1 month break due to winter holidays, but we are planning interesting topics for you on monthly basis. So keep joining us and be part of IBD series in the future as well. We are grateful and thankful to all the participants who have joined us along with our expert and Saya, Genix Pharma for the unrestricted educational grant, and of course our director, Professor Altaf Alam Sahab, and our team at PARSA ECHO Pakistan. So Allah Hafiz from now on. Uzair, you can please call off the meeting.
Sure, ma'am. Allah Hafiz, everybody.
Allah Hafiz.
Allah.